Hello and welcome to our final review lecture in the first year series. Just wanted to say it's been a great year and I hope we've been a little bit helpful, and I hope you enjoy this lecture and do well in your exams. So we're going to start talking about the lungs, covering the high yield pieces of physiology that could come up as MCQs, some of the conditions, pharmacology, and then finish off with some clinical pearls that they might not totally be yield right now, but it would be good just to have heard some of these things now, so when you see it later, it'll make a bit more sense. All right.
Hi everybody, my name's Hamish and I'll be discussing here some respiratory physiology with you today before we get into some of the respiratory conditions that you're meant to know for system medicine. So I thought we'd start by the central and peripheral respiratory control centers. So during ISM you learnt a lot about how gas exchange actually occurs and why it's important. But now in systems they're wanting you to know, well, how is it actually controlled? And really there's 2 points of respiration control. There is your central control and your peripheral control. So we'll start with central. So central control is done by central chemoreceptors. Essentially, these are receptors that are sensitive to changes in the chemical composition of the blood. Most specifically, these guys are sensitive to changes in pH in your cerebrospinal fluid, or your CSF. And the reason why there's a change in pH is that because CO2, or carbon dioxide, diffuses readily across the blood-brain barrier, meaning that it's very easy to get across there. So that means that pretty much the amount of CO2 that's in your blood is actually going to be in the CSF. So it pretty much mirrors it, which is great for central control of respiration. And what will happen here is if there's excessive amount of CO2 present in the blood, it'll diffuse through the blood-brain barrier and there will become an excessive amount in the CSF. And because of, as we know, CO2 becomes, through a chemical process, eventually yields more hydrogen ions. This is going to decrease the pH, and if the pH is decreased, this is sensed by the central chemoreceptors, and they work to increase ventilation through activation of the respiratory muscles. So that's the central control. The most important thing here is CO2. It's only sensitive to CO2. You've then got your peripheral controls, and these are also chemoreceptors that are found within your carotid and aortic bodies. Now, these mostly respond to arterial oxygen levels. So they're mostly responsible for oxygen. They do contribute a little bit to the CO2 response, but only about 40%. So the central control, the central chemoreceptors, are the most responsive to CO2. And furthermore, the arterial oxygen levels need to be pretty low for these guys to have a very major effect. However, once the oxygen levels get quite low, these will be activated regardless of the amount of CO2 that is present. So as I said, you've got your central and peripheral. Central is mostly is completely controlled by CO2. Peripheral is mostly by O2. So I've got little diagrams here of how exactly this works. I do want to note here that you might have read and you might have heard in your lectures about the DRG, VRG, pre-Botzinger complex, etc. These are pretty low yields, so I wouldn't really remember too much about them. If they do come up in the exam, I'll just give you a little rundown here now. So DRG, or dorsal respiratory group, this is essentially for quiet respiration, whereas your VRG is for your active inspiration and expiration, and your pre-Botzinger complex is essentially to control the rhythm of breathing. And essentially, if you haven't heard of these before, don't worry too much about them, but they're just brain stem centers that work to control your respiration. So now I'm going to talk a little bit about your acid-base control. So as you might know, pH is very tightly regulated within the body. Obviously, we don't want to be getting too basic or too acidic. And there's really 3 main systems that control this. We're going to be specifically speaking mostly on the respiratory system, of course, but I thought I'd just let you guys know that there's the chemical buffer, so you've got your bicarb and your phosphate. You've got renal mechanisms, which we're going to talk about when we talk about the renal system, and the renal mechanisms are you reabsorb bicarb, excrete H, And the key thing to note here is this is a chronic response. Takes a long time for the renal system to kick in. It's very effective, but it takes a long time. Whereas the respiratory system, this is the one that will be acutely responsible for changes in pH. So as we mentioned previously, this is mostly regulated by the central chemoreceptors, which when they detect raised CO2 levels or decreased pH, they will increase respiration so that you blow off more CO2 and reduce your blood CO2 levels to normalize the pH.
Lung volumes are something that you should really try and get your head around. So basically what you need to know is total lung capacity minus the vital capacity, which is the capacity with which you actually breathe, will give you the residual volume. That's one sort of essential part. The other one to kind of keep in mind is tidal volume and how tidal volume might change in certain physiological states. And then the rest you can kind of just piece it together as much as you need. Functional residual capacity and respiratory reserve volume, and then just this extra little bit of taking FRC minus RV to get ERV. You don't totally need to get all of this, but if you could at least remember total, residual, vital, and inspiratory reserve, that would be good, and tidal. These are flow volume loops, as opposed to flow time curves, which are another measurement. So flow volume loops have the lung volume as the x-axis, where the left is your full total lung capacity, and the right is your residual capacity, up from 0 liters. And the flow is in reference to that. Okay, with normal lung function, you get this nice shaped curve with expiration. And with restrictive conditions, you have the same shape of curve, but it's a smaller curve and you're breathing at lower lung volumes. And in the obstructive picture, because you can't empty your lungs, you're actually breathing at higher lung volumes with a higher residual volume because of the obstruction, and the curve shape also changes. The curve shape here is something that you should probably be able to identify, but hopefully if they gave you the x-axis, you would at least see that this thing is shifted over to the left. We're breathing at higher lung volumes. So that tells you that there's some kind of obstructive picture going on versus a restrictive picture. This is the volume over time curve, sorry, not the flow over time. And what I wanted to show here was the FEV1, which is the expiratory volume in 1 second of pushing as hard as you can. FEV1 is reduced in obstructive conditions, but it's also reduced in restrictive conditions. The thing that's different is the FVC, which is basically a surrogate for your total lung capacity. FVC will be a little bit lower than a properly measured total lung capacity because as you push that air out as fast as you can, you actually collapse some airways. So it's not a totally accurate measurement. But if you look at the green line versus the orange line, it's been shifted down, and that's because the volume of FVC is lower. What this means is that the FEV1 to FVC ratio is preserved in restrictive lung disease, because even though you've got a lower FEV1, you have a proportionally lower FVC. So of that reduced FVC, you're still able to get the normal proportion of it out in 1 second. Whereas in an obstructive condition, you still have that same FVC, but it takes you a long time to breathe it all out. So FEV1 is reduced with a possibly normal FVC. That's where you get the reduced FEV1 to FVC ratio. DLCO testing is the diffusion capacity of the lung using carbon monoxide. What the person does is, because carbon monoxide shouldn't normally be in your breath, if you breathe in some carbon monoxide, that carbon monoxide will diffuse from the alveoli into your blood, and then if you breathe out, there should be less carbon monoxide on your exhalation. The difference between the amount that you breathe in and the amount that you breathe out tells people how much of that carbon monoxide was absorbed into your blood, which is a surrogate measure for how well your alveoli are diffusing gases. Now, it's done to tell you if someone has something like emphysema in COPD, but also other lung conditions like interstitial lung disease. It helps to confirm that the diffusion capacity of the lung has been reduced by whatever disease process is going on. If it's decreased, obviously it can indicate emphysema, but as we said, it can also be things that interfere with VQ matching, so vascular diseases, heart failure. The thing to also take away from this is, so I just realized this slide says that smoking can increase your DLCO, but I kind of went on a bit of an adventure to figure out where they got that from. I'm not totally sure. My understanding, and from what I could read, is that it'll decrease your DLCO because the people that smoke have elevated levels of carbon monoxide in their blood already, which makes it a less favorable gradient for carbon monoxide to diffuse from the alveoli into the blood because the blood is already filled with some carbon monoxide. I'm not totally sure how it could increase it, so maybe just ignore that on this slide. I wanted to finish off my area of physiology by talking a bit about carbon dioxide transport and the Bohr and Haldane effects. So you should remember that CO2, the greatest proportion of it is going to be in the form of dissolved bicarbonate through the carbonic anhydrase equation. Then you have carbon dioxide that's bound to hemoglobin, but it's not in the actual heme part where oxygen binds. It's binding on the edge of the globin protein. And then dissolved CO2 itself makes up a small proportion. The Bohr and Haldane effects, all you need to remember is that the Haldane effect is what happens in the lungs, where lots and lots of oxygen being around promotes kicking off hydrogen ions from hemoglobin, and that oxidized form of hemoglobin that no longer has a hydrogen bound, it prefers to kick its carbon dioxide off, which helps CO2 be released at the lungs so that you can breathe it out. And then the opposite effect is the Bohr effect, where the acidic blood around your metabolically active tissues, that reduces the hemoglobin, which actually causes oxygen to be unloaded. So in the lungs, the Haldane effect promotes the unloading of CO2 because of the high levels of oxygen. And in the tissues, the Bohr effect favors the unloading of oxygen because of the high levels of hydrogen ions. So if you can just remember Haldane and Bohr, Haldane in the lung and Bohr in the tissues, that's enough.
Alrighty guys, we're now going to discuss VQ matching and VQ mismatching before moving on to some general pathologies that you guys need to know about the lung. So what is VQ matching? What does it stand for? So V stands for ventilation, and it's the amount of air that is moving within the lung, whereas Q is perfusion. It's the amount of blood that's moving within the lung. And really, these two things are entirely dependent on the location of the lung lobe, so depending on posture and gravity. And essentially, the lungs actively alter both of these factors, so ventilation and perfusion, to maximize the amount of oxygenated hemoglobin. And this kind of makes sense, right? Because if we have a segment of the lung that is not well perfused, but it's well ventilated, you're obviously not going to get enough oxygenated hemoglobin because there's no perfusion. Likewise, the same thing with a decreased ventilation, but a normal perfusion. You're not going to get maximize the amount of oxygenated hemoglobin. So essentially, the lung does various things to allow to actively change either or both of these two factors to maximize this oxygenation of hemoglobin. And really, this variation of ventilation and perfusion within the lung is called the VQ ratio, or VQ matching. So as I said, VQ, V for ventilation, Q for perfusion. So now just some general physiology stuff about the differences between the lungs and in the ventilation and perfusion of them. So for ventilation, the right lung actually has greater ventilation than the left in an upright and supine position. This is just a general physiological fact. As well as this, gravity squashes the lung segments that are lower, so you actually have an increased density and increased ventilation at these lung sites, the lower lobes, the very bases of the lobes. In terms of perfusion, it's the same thing with the right lung. The right lung has greater perfusion in a supine position, and perfusion increases progressively down the lung in an upright position. And this kind of makes sense because of gravity, because you can imagine the very apices of your lungs, they're the heart has to pump against gravity to actually get blood up there. So it kind of makes sense that they're less perfused compared to the lower lobes, lower down in the lung. So now I'm going to talk about when things go wrong and what the lung does to essentially counteract this. So this is what we're talking about here is VQ mismatch. So in pathological diseases that involve the lung, there's often a mismatch between perfusion and ventilation. And depending on which one is mismatched, there are two types of VQ mismatch that you need to know about. The first is called physiological dead space, and this is where you have high ventilation but low perfusion. Essentially, as you might remember, the stuff like the upper respiratory airway, such as the trachea, they're dead space because they have high ventilation but no perfusion. It's the exact same concept here, but now we've got a situation where this is happening inside the lung. And this results in a high VQ number, and as you can imagine, most times you'll see in textbooks and whatnot, they represent VQ as a number, and because it's a ratio, right, if you have a low Q, a low perfusion, and a high ventilation, you're going to have a very high VQ ratio because the Q is quite low versus the V. Now, what actually causes this? This is mostly caused, probably the most common one is your low cardiac output, so that anything that's going to reduce the perfusion to the lung. You can also have a PE, which is going to cause this. You get emphysema, you get anesthesia, and you get postural changes in age, which also lead to low perfusion. Anything that leads to low perfusion with not really that much change in ventilation will cause this. The second type of VQ mismatch is a physiological shunt. And this is where you have low ventilation and high or normal perfusion. Here you get shunting of the blood from an area of low ventilation to an area of high ventilation. Essentially, the key factor here is hypoxemia. It causes vasoconstriction. And what's really interesting is this is actually the opposite to what happens in the periphery, where hypoxemia will actually cause vasodilation. In the lung, it causes vasoconstriction because of this factor that we want to maximize the amount of oxygenated hemoglobin. Now, this physiological shunt type of VQ mismatch is caused mostly by pneumonia, pulmonary edema, lung collapse, obstructive diseases, hemorrhage, and obesity. It's anything that is causing low ventilation or not enough air to actually reach the lung. So I've got a little diagram here of what happens when each of these factors are occurring. So if your ventilation is less than perfusion, so as we mentioned here, what's going to happen is you're going to constrict the blood vessels, therefore you're going to have a physiological shunt that is occurring. So now we're going to discuss, moving on from VQ mismatch, we're going to discuss the type 1 versus type 2 respiratory failure, because this kind of does fit in with a VQ mismatch, and we'll talk about why in a second. So respiratory failure is when the pulmonary system is no longer able to meet the metabolic demands of the body, which kind of makes sense, right, because the respiratory system is failing. Now there's two main types for you guys to know. and they each have various etiologies. So there's type 1 respiratory failure. This is hypoxemia respiratory failure. It's the failure of the lungs to provide adequate oxygen needs to metabolic demands. Now, this is mostly caused by hypoventilation, so if you're at altitude, for example, a VQ mismatch, which we've just talked about, so anything that causes intrapulmonary shunt or a physiological dead space, this is what's going to cause potentially a type 1 respiratory failure. Now, the management here is supplementation with oxygen. You have mechanical ventilation, so you got CPAP, and also obviously you want to treat the underlying pathology. So I just want to flag here that you mostly learn about type 2 respiratory failure because it is a bit more common. However, it is still important to know how you differentiate type 1 and type 2. And as I said, type 1 is hypoxemia respiratory failure. Whereas type 2, this is hypercapnia respiratory failure. This is a failure of the lungs to eliminate carbon dioxide. The key thing here is that you will almost always have hypoxia because there's a failure to eliminate CO2. Obviously, this is going to mean that you're not getting enough ventilation somehow, and you're also going to have hypoxemia. But the key here is that they have hypercapnia, or an excessive amount of CO2. So if in your blood gases or in a question, an MCQ, you hear anything that says increased CO2 or excessive amounts of CO2, it's type 2 respiratory failure, regardless of what's happening to the oxygen. Whereas if you just see something as normal CO2 but hypoxia, that is going to be a type 1 respiratory failure. Now, this is because it's dependent on alveolar ventilation. The main causes are going to be your CNS depression. So if you have your opioids, drugs, for example. So then you've got your spinal cord pathologies, you've got your phrenic nerve palsies, respiratory muscle weakness, restrictive and obstructive lung diseases. Anything that's going to prevent CO2 from leaving the lungs. Now, the management for this is to increase ventilation and try and treat the underlying pathology. Great. So now we've finished all the physiology that we were going to cover in this. Now we're going to get into some of the good stuff, some of the conditions, some of the things that you've been learning about through your PVLs and what's important for the systems examination. So we're going to start with asthma. So asthma is a heterogeneous condition in both children and adults, and it's pretty much characterized, the key characteristic is variable obstructive airflow limitation. And I say variable because the most common type of asthma is atopic asthma, which is caused by an allergen, and we'll discuss this in a little bit. So really the three things that go on to actually cause asthma within the lung is you get accumulation of mucus in the bronchial lumen, so you get goblet cell hyperplasia. You get chronic airway inflammation from immune cells, and you get a thickened basement membrane, hypertrophy and hyperplasia of smooth muscle cells. So if anyone asks you what are the three things that cause asthma in terms of the actual within the lung, it's these three things. Now, depending on the type of asthma will determine how these three things started and how they occurred. As I mentioned, the most common type of asthma, and the asthma that most people think about when someone says asthma, is atopic asthma. And this is a type 1 IgE-mediated hypersensitivity. Essentially what that means is that it's triggered from allergens, and it's usually found in childhood and improves as a teenager. A sad fact for everyone who, as a child, had asthma as a kid, which was me, it's actually pretty common for it to come back when you're in your late 20s. So get excited for that. Now, atopic asthma usually has a positive family history of atopy as asthma, and this is how you can help to differentiate asthma from some other conditions, which we're going to talk about in a little bit. So then you've got non-atopic asthma. This is a bit of an interesting one. I'm not going to touch much on it here, but it's just for you to flag that it's not all atopic asthma. Now, there's no evidence of allergen sensitization with these patients, and it usually begins later in life, mostly from respiratory infections or inhaled pollutants. So in terms of, we're going to focus on atopic asthma here. In terms of the natural history, what actually happens is you get, I've got a diagram on the next slide which will sort of put these words into pictures. So you inhale the allergen, right? So you inhale the allergen for the first time, whatever it may be, you know, dust mites, cut grass, cockroach antigens or whatever. You then get an immune cell response with a massive amount of IgE production and eosinophil recruitment. So that's what happens initially. Now, on re-exposure to this allergen, you get an immediate early phase reaction where you get massive mast cell degranulation from the cross-linking of IgE. And this mast cell degranulation releases mediators for bronchospasm and mucus production. So here you got your histamines, you got your bradykinin, you got leukotrienes, stuff that is just going to irritate the airways and increase mucus production. You also get, from these mediators, you get recruitment of leukocytes, so all your one of your chronic and your late phase immune cells. And this starts the late phase of asthma, where you start to get inflammation and damage to the airway. So I've got a little diagram here. As I mentioned, you can see on the start, the side at the top, you've got the pollen or some sort of allergen, and this is going to essentially prime the immune system, prime the mast cells to respond to this particular allergen. You then go down on the left-hand side, on the bottom. In the immediate phase, you're getting that antigen present, and it's going to cause massive mast cell degranulation and increased vascular permeability, edema, and a large amount of mucus secretion. And then in the late phase, you can see you've got recruitment of your leukocytes, and you've got the damage and inflammation of the airways. So this is great to lead into COPD, because I'll let you know now is that both of these, asthma and COPD, they're both the major obstructive diseases that you guys need to know. And just to flag here that actually in the adult, it can be quite difficult to determine between COPD and asthma. So I'll just flag that now, but now we'll discuss a bit more about COPD. So chronic obstructive pulmonary disease, so COPD, it's an umbrella term to describe two real clinical syndromes that are associated with the destruction of the lung and airway obstruction. So it's an obstructive disease. And the two diseases that you need to know that sort of make up COPD, and they exist on a spectrum between the two of them, is emphysema and chronic bronchitis. And we'll talk both about these specifically in a minute. So what actually causes COPD? Now, almost 80 to 90% of COPD is caused from chronic exposure to cigarette smoke. There is, of course, a small amount that is from exposure to toxic particles and gases, so stuff like biomass fuels or any occupational hazards. And then a smaller subset, there's also a cause from the one that you guys need to know is this alpha-1 antitrypsin deficiency. And it's the most common cause of emphysema in young patients with no history of smoking. So if someone presents to you as a young patient, young in their 20s, and they have an obstructive disease, they're a non-smoker, they haven't had any occupational hazards, you want to be screening for this alpha-1 antitrypsin because if it's deficient, it will cause emphysema and thus can lead to a COPD. So I've got a little diagram here to sort of show the difference between chronic bronchitis and emphysema. And the main difference is when you think of chronic bronchitis, think of inflammation, sticky mucus that is sort of clogging up the airways. So very similar to asthma in a way, but it's that mucousy, inflamed airway. Whereas emphysema is a little bit different. Emphysema, what happens is you actually get damage to the air sacs themselves. They become dilated and they actually become unable to let air out of the alveoli. So therefore you get this gas trapping, similar to chronic bronchitis, where the gas sort of sits in the airways and it can't actually get out. So this is pretty much a slide saying what I've just said. So emphysema is the irreversible enlargement of air spaces distal to the terminal bronchiole with destruction of the walls due to fibrosis. And it's mostly due to cigarette smoking and other noxious particles. Essentially, the key here is you get parenchymal destruction of the airway. Now, chronic bronchitis, the definition of chronic bronchitis is more of a clinical one. So it's one that has a persistent cough with sputum for 3 months in at least 2 consecutive years. So as I mentioned in the previous diagram, chronic bronchitis is essentially you get mucus plugging of the airway. So that's where that mucus is coming from. And it's mostly due to cigarette smoke and other noxious particles. And it causes mucus hypersecretion, hypertrophy of mucosal glands, and inflammation. So it is similar in some senses to asthma, but in this case, it's a chronic condition that is caused from progressive destruction of the airways. Now, we're going to touch, so we're just changing tact completely now from obstructive diseases. We're going to now talk about lung cancer. And there's a couple of things, there's only 3 major things you need to know about lung cancer, and this mostly comes up in pathology. So I've got some pathology slides in a moment. You don't really need to know how these cancers form and like what is the process that they form or what's their complications. What you need to know is honestly these 3 things that I'm going to talk about. So the first one is the location. Location gives the type of cancer that it is. So a little thing that we worked out is, myself and Wadir, shout out to him, is that everything that sounds like S goes together. So central, smoking, squamous cell and small cell carcinoma. Say that again, central, so if they're found centrally in the lung, centrally meaning the large airways, you've got smoking cancers and they're squamous cell and small cell carcinomas. That leaves only one major other one that you need to know, which is an adenocarcinoma. This is found in the periphery and it's usually a non-smoker. So location, that's the first thing you need to know to differentiate the lung cancers. Next, you've got the paraneoplastic syndromes that these cancers are associated with. So essentially a paraneoplastic syndrome is sort of a byproduct of the presence of the cancer there. So you may have heard of stuff like cachexia, the night sweats, fevers. Those are paraneoplastic syndromes in the sense that because the cancer is present, it'll be causing these things. But sometimes the cancers actually secrete specific things, and they are also termed paraneoplastic syndromes. So small cell carcinomas are well known to secrete 2 main things. They can secrete SI-ADH, they can secrete ADH, which results in SI-ADH, or syndrome of inappropriate ADH secretion. And essentially, obviously, what's going to happen here is because you have excessive amount of ADH, you have excessive amount of water reabsorption at the collecting ducts, and you're going to get hyponatremia. The small cells can also secrete ACTH, and ACTH is essentially secreted usually by your pituitary to induce your adrenal glands to start secreting cortisol. And if there's an excessive amount of ACTH, this can cause something called Cushing syndrome, and you'll learn about this a lot more in P4P next year. But it's just good to flag here that an increased amount of cortisol will result in something called Cushing syndrome. Next, you've got your squamous cell carcinoma, and this is most well known to secrete PTH. And with here, you're going to get hypercalcemia and weak bones because PTH, as you might know, works to increase calcium, blood calcium levels, and it mostly does this through actions on the kidney, but also to increase bone remodeling and to release the calcium phosphate stored within the bones. So now we're just going to get into some pathology. So this is the third thing you need to know. It's the pathology, what they actually look like. So the first thing on the right, we've got a squamous cell carcinoma. How you can tell this is a squamous cell carcinoma, and this is what you need to know for the pathology exam, is you have nests of atypical or pleomorphic cells. So nests, that's the first thing. You have distinct cell borders, that's the second thing. And you have keratin pools, and the keratin pools is that sort of a pinky bit in the center here. So those are the 3 things to know: keratin pools, nests, and distinct cell borders. Next, we got adenocarcinoma. That's the second one. You have to know what it looks like on a pathology slide. And here, for honestly, anything, because adenocarcinoma, they come from any tissue that has glands. Adenocarcinoma can come from that. So this is true for every single tissue within your body. If you see something that has back-to-back glands and has mucin secretion in the middle of it, it's going to most likely be adenocarcinoma. If you see something and you don't see any keratin, and you can't really see what else it is, it's adenocarcinoma until proven otherwise. Adenocarcinoma comes up a lot on the pathology exam, and honestly, if you guess it, I'd say you have a much better chance of guessing it right if you just guessed adenocarcinoma. Now, what's an important marker to know for lung-specific adenocarcinoma is TTF1, or thyroid transcription factor 1. This is an embryological marker of lung tissue, and it's used to differentiate a metastatic versus a primary adenocarcinoma. Because you can imagine, of course, the lung is a common site of metastases, so to actually know if the cancer came from there, we look at if it has TTF1, if it's at a primary from the lung. I haven't put up a picture of small cell carcinoma because it doesn't really come up on exams, but if you see anything that's really blue and very celly, like lots of cells, it's a small cell carcinoma.
Okay, let's talk about Croup. Now, Croup is one of the most common infectious pediatric conditions that you'll see. It's basically an upper airway inflammation, otherwise known as laryngotracheobronchitis, and it's commonly caused by viruses. They're actually similar viruses to those that cause bronchiolitis in younger children, with paraflu being the most common. And essentially you get inflammation of the upper airway, which will lead to a inspiratory stridor because you've got a narrowing outside of the thorax. It sort of peaks around 6 months to 3 years old, and the things you should know is that because it begins as a viral infection, you'll have coryzal symptoms, so runny nose, some fever, feeling a bit unwell, and then they end up with this barking cough, hoarseness of voice, and a inspiratory stridor. It can get quite severe if the airway narrowing is significant, and they can end up with shortness of breath at rest and signs of respiratory distress, which include head bobbing due to use of the sternocleidomastoid, intercostal recessions, subcostal recessions, substernal recessions. You should look up all of those things to make sure you know what it looks like, but once you see it once, you won't miss it. And that's all just the use of those accessory respiratory muscles because of increased work of breathing. It's basically a clinical diagnosis, and look, you shouldn't really do anything here because the more that you manipulate the child, the more upset they'll get and the more clinical deterioration there'll be. You should actually keep the child very calm, take a very hands-off approach, and sort of review from afar. Bronchiolitis is a pediatric condition I wanted to add to this lecture because it's very common and you'll be asked about it a lot in third year, but you might not actually get taught very much about it at all during first and second year. So what is it? It's a lower respiratory tract infection of the bronchioles via a virus, typically. In children less than 2 years of age, it's a clinical diagnosis. You don't need any investigations, and the management is completely supportive with promoting oral intake and oxygen if you need it, based on their SpO2. Caused most commonly by respiratory syncytial virus, but can also be caused by paraflu, human metapneumovirus, influenza, adeno, rhino, and coronavirus. Not the coronavirus, but many, many other coronaviruses. The clinical cause is initially they get a runny nose or fever, which is the viral prodrome of basically any viral illness. Around day 3 to 4 following that, they start to cough, get tired, they're too weak to drink their normal oral intake, the number of wet nappies might decrease because they're dehydrated, and they might begin to show signs of respiratory distress, such as nasal flaring, tachypnea, recessions, which can be subcostal, intercostal, and substernal. They might also be moving their head with each breath as the accessory muscles contract, called head bobbing. By day 5, it gets the worst, and then within a couple days after that, it just gets better on its own. So this is just a table from the RCH, Children's Hospital Guidelines, which are an amazing resource for pediatrics. There's mild, moderate, and severe. Severe cases might require alerting the ICU, whereas mild and moderate are very easily managed on a ward, and if it's mild with good oral intake and normal wet nappies, maybe they could even go home. The therapy is oxygen, based on keeping their saturations above 90, or at least at 90. And that will depend on where you go. People have all different numbers, like 92, 94, 96. Hydration and nutrition. So if they're not drinking and eating, you can consider a nasogastric tube to provide fluids. And if you need it, you can use IV fluids. But in pediatrics, there's actually a study at the moment at Gold Coast Hospital of, is there any difference between nasogastric fluids and IV fluids for bronchiolitis in certain severities? And overall, it sounds like there is no difference. So you don't need to be putting cannulas into babies or 2-year-olds. You can just give them lots and lots of oral fluid, and their gut will absorb that fluid. There are no drugs that should be used for bronchiolitis. So this could be a good trick question of, you might start thinking of giving salbutamol or nebulized adrenaline or steroids, but it's not one of those lung conditions that you've learned. This is another one that's purely conservative management of a viral infection. So here you go. Don't give anything. Don't do nasal suction. Don't do chest physio. Epiglottitis is a rapidly progressing inflammation of the epiglottis, characteristically caused by Haemophilus influenzae B. That was in the age before vaccination, but it can still cause it in people who are vaccinated, and there are also people who aren't vaccinated, and there are also other organisms that can cause it. The clinical features are that they look unwell, toxic, which is another word for septic, which is another word for unwell, and they'll have a fever. So when I say toxic, basically they're floppy, lethargic, not themselves, they're not running around, they're not crying like usual, they don't want to look at you, they just want to flop over mum's knee. And the key feature is that they'll have a stridor, which could be croup, and most commonly stridor is associated with croup. But it could also be inhalation of a foreign body, which we'll talk about later. And finally, it could be epiglottitis. The thing that happens in epiglottitis is that they have difficulty swallowing, their voice and cry will be muffled, they'll be restless and agitated because they're struggling to breathe, and they will drool. So between croup, foreign body, and epiglottitis, drooling points towards foreign body and epiglottitis because you're having difficulty swallowing your secretions, whereas in croup they shouldn't drool. And in croup, they will have a cough, and they would have had a viral prodrome. In epiglottitis, they'll suddenly become unwell, start drooling, and get a stridor. So there are some clues of the history to sort of manage risk here and decide what should you do and what could be going on. Because obviously you don't want to be getting ready to intubate everyone that actually has croup. And the treatment at least involves airway management, and then some other steps, but you don't need to know many details. So if they have the barking cough with stridor and they, have a fever, that strongly suggests croup. But if there's no cough and there's a stridor and drooling, that suggests epiglottitis. And if it's a very sudden onset, especially the question stem of all pediatric exams is that it's summer and they're at a Christmas dinner or something, or a picnic in the park. No one's watching the kid and the kid's gone and picked up a peanut and breathed it in. That suggests inhaled foreign body. And obviously stridor or upper airway obstruction could also be anaphylaxis, which would have its own group of things, the urticarial rash, wheeze, and angioedema. Here is an X-ray of a child who is fully breathing out in this picture. Okay? So when you breathe in, both lungs should look black. But when you fully breathe out, both lungs should look white. This right lung here, it doesn't look white, and that's because it's obstructed by a foreign body, which means it's hyperinflated and you can't exhale the air out of the lung. So this is an X-ray of a child that's breathed in a foreign body. So you always need to get erect inhale and exhale films, because if it's just an inhalation film, you might miss the diagnosis. So this is an X-ray of a foreign body inhalation that's obstructing the right main bronchus, so that the whole right lung is hyperinflated. Diaphragmatic hernia is something that you learn in anatomy, and every so often there's an MCQ on it, so why not? It's kind of common. Most of them are left-sided, but some of them are right-sided, and the interesting thing about right-sided is it almost looks like a pleural effusion because it's just a big white thing up in the chest. It's actually the liver. So instead of being loops of bowel on the left side, a right-sided diaphragmatic hernia is actually the liver up inside the chest. They're either detected soon after birth or before birth, and the mortality is mainly from failure to develop the lungs properly. The diaphragm should be fully developed, but what happens here is those pleuroperitoneal membranes fail to fuse, and so you end up with an incomplete diaphragm and abdominal contents get pushed up into the thoracic cavity. And here's an X-ray of a left-sided congenital diaphragmatic hernia with some loops of bowel up where the lung should be and a shifting of the mediastinum. So you should also be aware that there can be acquired or other forms of diaphragmatic hernia where little loops of bowel will go through the very anterior portion of the diaphragm or posteriorly where the aorta is. Those are things that happen in adults and are more of a surgical topic rather than what we're talking about here. Tension pneumothorax is a medical emergency, and essentially it's a collapsed lung with a collection of air in the pleural space. And if it's a tension pneumothorax, it's actually building up pressure within that space, leading to a mediastinal shift, which can lead to reduced venous return and obstructive shock. What basically happens is you end up with a one-way valve that lets air into that space but doesn't let it go out again. And the most common sort of area that you should know this from is something like a car crash with rib fractures. But it can also be from other things and even from medical things like putting in central lines and using too much pressure with ventilation and bursting a bulle or something. This is just a slide showing you that valve mechanism that in the right side that space is getting larger and larger associated with mediastinal shift, and that the air can't escape. It's stuck in that pleural cavity. The clinical features are a pleuritic chest pain, reduced or absent breath sounds on that one side where the pneumothorax is happening, hyperresonance to percussion because you're tapping on a hollow chamber, respiratory distress, reduced chest expansion, and due to that mediastinal shift and obstruction of the vena cava, you can get signs of shock like distended neck veins suggesting poor venous filling, and hemodynamic instability, tachycardia, and hypotension combined. Here's just some X-rays to show you the tension pneumothorax. So if you look at the trachea here, it's deviated. You've got a big black area where the lungs should be. That's a very serious tension pneumothorax. This is a chest x-ray that you should be able to identify, so make sure you go through it a couple of times. Going systematically through the A, B, C, D approach, it's the A and B in this one that gives you the clue, and I guess also the C, because when you look for the heart, you go, oh, where's the heart? Okay. Pleural effusion. It's an accumulation of fluid within the pleural cavity. So make sure you put this in a different part of your brain compared to pulmonary edema, which is fluid within the interstitium of the lung, or the parenchyma of the lung. This is fluid around the lung in the pleural cavity. It can be a transudate or an exudate. Exudate is obviously the high protein, high cellular, sort of inflammatory, infectious, or malignant fluid, whereas transudate is more of a clear flowing of fluid that's low in those things, secondary to changes in pressure dynamics, either due to low albumin, like a decreased oncotic pressure, or increased hydrostatic pressure going into the lungs, like congestive heart failure, because you can't drain blood out of the lungs when your left heart fails. The features are shortness of breath. A dry, non-productive cough can happen. On auscultation, the best thing is either reduced breath sounds or the presence of some crepitations or crackles over that area that will be collapsed underneath the fluid. And dullness to percussion, especially stony dullness, is a strong indicator of pleural effusion. Chest x-ray is enough to give you the diagnosis. AP and lateral views, because the AP view, it might not look like there's a lot of fluid, and then you get a lateral view and you see that, it's like 1/3 of the chest is filled with fluid. And if you're concerned that, someone's had a pleural effusion and you think it might be cancer, you can get a sample of that fluid and apply Light's criteria to decide if it's a transudate or an exudate, and you can do cytology to look for cancer cells. This should be especially a part of your workup if someone had, say, breast cancer, that could easily go to the chest wall and cause a malignant pleural effusion. But also, many other cancers can go to the chest wall. Basically, you need to treat the cause. You can put in tubes and drain fluid, but typically, if it's not too bad, you can just treat the cause, and that will resolve over time. That fluid will be reabsorbed naturally. And here's just a diagram showing you a left-sided pleural effusion that's, that's a large pleural effusion. It's going all the way up to the middle there. That's probably a lot of volume, even though it might not look that scary from the front. Pulmonary edema, on the other hand, that's the condition where you have fluid within the actual lung tissue itself, leaking out from the capillaries, and it can compress the alveoli, and that's why you get those crepitations when they snap open against that fluid. Most commonly, it's caused by the heart, or at least in the hospital setting, caused by the heart. People with left-sided heart failure come in with a cough and shortness of breath, and it's secondary to pulmonary edema. Because of the sort of pressure dynamics within the lung, pulmonary edema and small pleural effusions can often go together, but make sure in your mind that you separate the two concepts. Pleural effusions are fluid outside the lung, and pulmonary edema is inside the lung, and the chest x-rays look very different for the two. You can have non-cardiac causes like respiratory distress syndrome, PE, other sort of inflammatory processes going on inside the lung. But heart failure would be probably the best one to know very, very well, because you'll just see it a lot. Because of that fluid, which can actually end up inside the alveoli, or at least compress the alveoli, your ability to diffuse oxygen across that membrane is significantly reduced, because that swelling with fluid increases the difference between the alveolar membrane and the capillaries. So carbon dioxide gets across okay because it can rapidly dissolve in water, and it's like 20 times higher coefficient than oxygen. But oxygen will get blocked, so that's diffusion block. Now, something you should be aware of in the lungs is the AA gradient, the gradient of oxygen in the alveoli versus the arterial blood. And that will tell you if there's a high alveolar oxygen, and a low arterial, that means that even though the oxygen's getting into those alveoli, it's being blocked from dissolving into the arterial blood. So the AA gradient can give you a clue here as to whether it's a diffusion block kind of respiratory failure secondary to this fluid. But clinically, you don't really need that, right? Someone with heart failure and shortness of breath, with a chest x-ray that looks like pulmonary edema, you can call it pulmonary edema and treat them symptomatically with a loop diuretic. The one that you should really know about is paroxysmal nocturnal dyspnea and orthopnea. Orthopnea is that positional shortness of breath when you lay flat, and so you should always ask people how many pillows they're sleeping on. People will adapt to this shortness of breath and they'll learn to sleep on 5 pillows, and paroxysmal nocturnal dyspnea is when in the middle of the night you wake up short of breath. They are both strong indicators of heart failure. Heart failure can be a very clinical diagnosis. You don't really need an echo to know that those things are abnormal, right? Here's an x-ray showing pulmonary edema. Now look, I'll say in the hospital they don't all look this nice. Sometimes it's just a little bit of fuzziness down the bottom, but what you're basically looking at here is fuzziness. You might see some things like those curly lines or bronchovascular markings at the cephalic region, basically the heart failure x-ray that we talked about in the cardiovascular lecture. But yeah, and air bronchograms are the sort of the tubes being surrounded by fluid that you'll see every so often. There might be one here, possibly. What you should basically know, and I think this is definitely one here, if the lungs look fuzzy and someone has heart failure, you can be pretty confident that it's pulmonary edema. This is across all lobes of the lung, so don't get it confused with pneumonia, which is commonly lobar, and you'll see it, isolated to one lobe, and it's a very dense consolidation, whereas this is fuzzy and you can still see some black underneath the haze.
Just wanted to highlight the general differences between viruses and bacteria in terms of what they do to the body. So viruses are not alive. They have to replicate using the machinery of the host cell. So they invade your cell and then use your enzymes to copy themselves and build themselves a new shell. Whereas bacteria are living organisms and can grow in lots of different environments, and they don't need a host, except for a couple of bacteria which actually do need to invade cells, and these include rickettsia and chlamydia. Generally, the symptoms of a viral infection are due to the immune response to the virus. So flu-like symptoms, which happen to be the symptoms of every single viral infection, are actually the immune system releasing TNF-alpha and other inflammatory cytokines causing those symptoms. So the reason why hepatitis A and HIV and coronavirus and rhinovirus and influenza all kind of have flu-like symptoms in the beginning is because that's actually your immune system responding to the virus. That's not to do with the specific virus necessarily. And then later on in the course of the disease, you get some specific things that occur because of the genes that are in those viruses. So Ebola is very different from hepatitis C. But in the beginning, there are general flu-like symptoms mediated by the inflammatory response of the immune system. Whereas bacterial infections, they cause symptoms that you notice based on where they are and what they're doing. So if bacteria are producing acidic substances and toxins and invading into tissues and creating pus and an abscess, you notice that at the site of infection. Like a boil on your skin infected with staph causes pain and inflammation and pus on your skin. You don't get flu-like symptoms necessarily. And so, as we said, viral illnesses have the viral prodrome of flu-like symptoms. So before getting viral pneumonia, you'll have runny nose, cough, the general viral fever, malaise. Whereas bacterial pneumonia, you might notice nothing, and then suddenly you have this worst cough that you've ever had in your life with pussy sputum. Bacterial infections can sort of have no symptoms in the beginning, in terms of systemic features. So, for example, a urinary tract infection, all the symptoms might be isolated to the urinary system, whereas a viral infection would give you systemic features of flu-like symptoms with the viral prodrome. A bacterial infection is really located to where those bacteria are, at least at first. Then later on, when the bacteria spread out further into the tissues or form an abscess or enter the blood, then you get systemic features that are quite severe. Like if a UTI becomes urosepsis, then you're on the brink of death.
Okay, so pneumonia is when we have inflammation of the alveolar spaces or the interstitial tissue of the lungs due to an infection. And I've just listed some common bacteria or viruses responsible here. It's good to know that you have both community acquired and your hospital acquired. And for your community acquired, it's not just the Streptococcus pneumoniae. It's good to know still about the Klebsiella, the Haemophilus influenzae. And for the atypical, you might be asked to actually list, atypical bacterial causes of pneumonia, so your Mycoplasma and your Chlamydiophilia. And then for your hospital-acquired infections, good to know that's primarily due to your Staphylococcus aureus. And just at the bottom there, don't forget that viruses, can still be responsible for pneumonia. So, like we said, we've got typical pneumonia and atypical. So typical, it's going to have your classic symptoms, your the typical findings that you've learnt with your auscultation and percussion, and that's mainly your lobar and bronchopneumonia. Whereas your atypical pneumonia typically manifests as the interstitial pneumonia, and they won't necessarily follow those distinct classical patterns, and may actually have unremarkable findings. Just as a classification at the bottom there, you've got your lobar pneumonias, and that can either be multilobar, so involving like many lobes in the single lung or across both lungs, and panlobar involves like all the lobes of a single lung. Bronchial pneumonia, so all the tissue around the bronchi or the bronchioles, and interstitial pneumonia being the tissue between the alveoli being affected and inflamed. So, pathogenesis, what's happening here? We've got a failure of our protective pulmonary mechanisms, so your cough reflex, the mucociliary escalator clearance, your alveolar macrophages. It's actually good to know your respiratory immune mechanisms like that as well, because that could make a good little SAQ. And then because you have a failure of that, you have your pathogen infiltrates the parenchyma, and then you get a lot of your inflammation, your damage, all of the inflammatory infiltrates. And then what's that actually going to do? So that's going to impair the alveolar ventilation, increase that gas perfusion distance, and so you will get a ventilation perfusion mismatch, and then you will get a intrapulmonary shunting, so that right to left shunt. And so this is caused by having that continued blood flow to the consolidated, poorly ventilated areas, resulting in passage of blood from the right heart to the left heart without oxygenation. So that's where that right to left shunt comes in. And that's going to lead to hypoxia, because like we said, that increased alveolar arterial oxygen gradient, and ultimately having impaired gas diffusion. So clinical features, so if you're going to have a stem, what are they presenting with? What's there to be aware of? So just highlighted here, your crackles, those decreased bronchial bass sounds, the tactile fremitus, the dullness with percussion. You'd also see, increased breathing rate, the difficulty like shortness of breath. So just being aware of those ones there, the fever from infection. And then with diagnostics, this is just, very brief here, just a little summary, but with your lab studies, so you'd look at your inflammatory markers, so you'll see reactive protein, erythrocyte sedimentation rates, and then being aware, like we said before, that these might actually be quite unremarkable in your atypical interstitial pneumonia. And then for your arterial blood gas, so you'll see a decrease or a low PaO2, and then your oxygen saturation could be below 94%. You can also do your microbial studies, so your blood cultures, sputum cultures, gram stains, nasal swabs, just depending on the type of bacteria. And then you would do a chest x-ray. And so just place there, what to look out for on an x-ray. So if it's, lobar, looking for opacities in it's kind of defined to a lobe. Bronchial will kind of be poorly defined. It'll be patchy. You'll see your air bronchograms. And then with interstitial, it can be like this diffuse reticular opacity. You can look up on Radiopedia how all of them look on a chest x-ray. I've just popped a lobar one up there. And that they're really good to look at as well, just to get comfortable with differentiating between them. So here is just from the ETG about the management. So it does depend on, the severity, the severity of the pneumonia they have, and also, like we had in the other one, your cultures when they come back. But, if it is a low severity, you can see there, it's usually monotherapy or just oral antibiotic. But if they can't actually be reviewed within 48 hours, you can consider a dual therapy, combination therapy. Or if they've been on a monotherapy and they haven't improved within the 48 hours, consider that combination therapy. And so I've kind of just popped that there. The main difference between your community acquired and your hospital acquired is to have with your monotherapy, you'd combine it with a beta-lactamase inhibitor, and then your combination therapy having both an anti-pneumococcal beta-lactam and a macrolide. And then for duration of therapy, ETG pretty much just have for most of the community acquired 5 days, hospital acquired usually is 7 days for even if it's mild, intermediate, severe.
Tuberculosis is a unique infection by Mycobacterium tuberculosis that has infected over 1 billion humans worldwide and kills over 1 million people every year. It's got a unique pathogenesis where the bacteria enter your macrophages by phagocytosis, but instead of the macrophage being able to destroy the bacteria live inside the phagosome, and through factors that the bacteria has, it actually prevents the macrophage being able to destroy it. So then the bacteria grow inside of the alveolar macrophages in your airway, and after a few weeks, then finally you get a T helper 1 cell response because the macrophages have realized that they're unable to destroy this bacteria. The T helper 1 cells then produce interferon gamma to make those macrophages become activated. That's what then leads to this massive inflammatory response that leads to caseous necrosis and granuloma formation. Now, hopefully, those activated macrophages will do the job and destroy the bacteria, but that'll be at the cost of healthy lung tissue or other tissue if the TB has spread. But unfortunately, the TB can still survive even after this enhanced immune response. So you've destroyed your lung and you've still got the bacteria in there. And later in life, the bacteria can come out again and you'll go from latent TB to active TB, secondary. So things like HIV and immunosuppression can bring back your TB that's become latent. So this is the general pathophysiology, and it's a pretty tricky diagram, but basically if you start in the bottom left, you get your primary infection and that might then lead to caseous necrosis, and then at the top left, you'll heal and all the bacteria are dead, and that's it. You had TB and you survived. And that happened, right? Not everyone in the world died. But a lot of people progress from that primary response with necrosis to having latent lesions, which is basically TBs living inside these granulomas walled off and ready to come out again later in life. Alternatively, you can go from the primary infection to primary progressive TB, where the TB breaks off into the blood and spreads to other organs. So one of my family members had TB in their kidney. Anyway, so TB reactivation to secondary TB in someone with latent TB will then cause another massive immune response in these already necrosed lungs. You'll get more necrosis, and you can end up destroying your entire lung and dying from that. Or again, they could break off into the blood and spread to other organs. This is what a TB granuloma looks like on the right. So you've got the macrophages and bacteria in the middle, surrounded by Langerhans giant cells and T helper 1 cells like a halo on the periphery. The general symptoms look a lot like cancer, so night sweats, hemoptysis, lymphadenopathy, malaise, anorexia, weight loss, and fever. But generally speaking, people with latent TB have no symptoms, and people with early active TB might not even notice that they have it for quite a while. And so that's why it's really good at spreading, because you might just have this weird cough, and TB's airborne. You need to wear an N95 mask to protect yourself. It's not just droplet like other conditions. So it's really easy to spread in a household or in a community. In terms of radiology, these granulomas, when they get big, are called a Conn lesion or Conn complex. And when that calcifies, it becomes a Ranke complex. So a Ranke complex and a Conn complex and a TB granuloma are all the same thing, just at different stages. And Ranke complexes, because they're calcified, can be seen on a chest x-ray and help you to diagnose TB. And in terms of pathology, make sure you know the different kinds of necrosis and that this causes caseous necrosis, and that the giant cells of a TB granuloma have the Langerhans morphology. I'm not going to go through them, but I want to point your attention to the AMH, where you can have a look at the different drugs used to treat TB. And the most common combination, and the ones that are worth knowing, are isoniazid, rifampicin, ethambutol, and pyrazinamide. And just as an aside, because it'll be interesting for you next year when you do your neurology block, isoniazid can cause seizures. So I was listening to an emergency medicine podcast the other day where they had a medical student come in who had been on placement in India, and he was having seizures. And the reason he had seizures was because of isoniazid. He also had metabolic acidosis, and isoniazid can cause metabolic acidosis. They used to recommend that if you were taking isoniazid, you need to take pyridoxine, which is, I believe, vitamin B6, to reduce the risk of peripheral neuropathy. But now they're saying you don't have to do that for everyone. But certain at-risk populations still will need it. This is a fairly new thing, and your exams might not be updated to reflect this, so just try and remember the pyridoxine thing anyway.
So phrenic nerve palsy, I just wanted to throw it in because it's something that comes up in anatomy. You know that the phrenic nerve runs along either side of the heart and, that medial surface of the lung hilum. So some of the things that could damage the phrenic nerve would be lung cancers, especially bronchogenic cancer. But also other things like trauma and nearby inflammation or compression by an aortic aneurysm that's large enough. But I just want you to be aware that it could be a sign of lung cancer, and this is what the X-ray will look like. So on first inspection, you might think that this is a pleural effusion, but the clue here is that the costophrenic angle is more or less preserved here, right? It comes down to a point, whereas an erect pleural effusion will typically have that meniscus curving the other way, or if it's associated with air also being in the lung, it'll be flattened, but it definitely won't be curving down. The curving down that you're seeing is the diaphragm itself being raised superiorly, and because its connection to the rib cage is preserved, you get this curving all the way down from up here down to the rib. So it could be mistaken for a pleural effusion, but it's definitely not a pleural effusion. And that's because of, if you look in this film, there's an opacity in the right upper lobe of this lung that ended up being a cancer that was compressing on the phrenic nerve, causing phrenic nerve palsy.
Alrighty, so now we're going to discuss a little bit about the pharmacology of the respiratory system. So we're going to start with asthma, move on to COPD, and then talk about croup, and then go on to cancer. So, start with asthma. So in terms of the management of asthma, the long-term goal is symptoms control and to reduce the risk of flare-ups and adverse drug reactions, and also to reduce the airway limitation. So how this is done is through two main classes of drugs, or general classes of drugs. You've got your symptom control or your relievers. And these essentially work to relieve, as the name implies, to relieve the symptoms of an asthma attack or just asthma in general. And so this is done mostly by your beta agonists. Essentially, the beta agonists, they induce bronchodilation by working on the beta-2 adrenoreceptors, but they also do quite a few other things. They actually stabilize mast cells, they reduce edema, enhance mucus clearance, and inhibit TNF-alpha monocytes. And you break down the beta agonists into two main classes for asthma. This is your SABAs and your LABAs, so your short-acting beta agonist and your long-acting beta agonist. Essentially, the short-acting work within 2 minutes and last 3 to 5 hours, whereas the longer-acting usually last 8 to 12 hours. So then you've also got in your symptom control, your relievers, you've also then got your muscarinic receptor antagonists. And these essentially work to inhibit your M1 and M3 cholinergic receptors to relieve bronchospasm and decrease mucus secretion. Because normally, acetylcholine is released from the vagal nerve endings to induce bronchoconstriction and increase mucus secretion. And there's two types here as well, like the beta agonists. You've got your SAMAs and LAMAs. And so you've got your short-acting muscarinic antagonists and your long-acting, very similar to your beta agonists. And the adverse effects here, I just wanted to flag it, is your anticholinergics. Anytime you have anticholinergics, if you remember, hot as a hare, blind as a bat, dry as a bone, red as a beet, mad as a hatter, those are some great ones, pretty high yield ones to remember. Just a little to flag it here, for your LAMAs and your LABAs, these are kind of still considered relievers, but they also act as a sort of a bridging between your relievers and your preventers. So they're a bit of a mix between the two. So your SAMAs and your SABAs, of course, they are 100% relievers because they're going to act very fast. But your LAMAs and your LABAs, they're sort of a bridge between, and they're not a true reliever, so to speak. You've got now some other ones. So you've got methylxanthines and you've got your magnesium sulfate. Most of these here are designed for an acute asthma attack. So now we've got the prevention of the risks. So we wanted to reduce the airway remodeling, and we want to reduce essentially the airway limitation. And here we've got stuff that's called preventers. And the main preventer here, one of the most effective for asthma, is corticosteroids. Essentially, these have an anti-inflammatory action. For you guys to know, it just reduces the hypersensitivity and reactivity of the airway and reduces the frequency of asthma exacerbations. And it does this by inhibiting phospholipase A2, which prevents leukotriene synthesis. However, corticosteroids, you can think of them like a shotgun. They're a shotgun drug to treat anything that is inflammatory, right? Because they do a lot of things. They work to gene modulate a lot of things. So just knowing for you guys that it prevents leukotriene synthesis, just know they do a lot more, but it can be summed up by saying they're anti-inflammatory. And usually they're almost always inhaled, so obviously this is going to restrict their use to the lung. They're very rarely used orally, in fact not at all for asthma. It'd be very rare to do because of the side effects. For your other preventers, you've got your mast cell stabilizers, you've got monoclonal antibodies against human IgE, and you've got your leukotriene receptor antagonists such as montelukast. So these are just some other examples of preventers. However, most commonplace is the use of corticosteroids. So now moving on into COPD. Just so you know, this can be broken down into two main sort of management steps. The first is non-pharmacological, and for here the most important one is smoking cessation and physical activity. Smoking cessation is the main cause of COPD, so it kind of makes sense that we sort of try and stop it as much as possible. For your pharmacological intervention, it's pretty much the exact same as asthma. You've got your relievers and your preventers, and they do the exact same things, right? The key here is that corticosteroids sort of have mixed efficacy. They can actually cause pneumonia and other side effects, so they're not that effective for COPD as they are for asthma. That's just something to flag there.
As I alluded to earlier, the treatment of croup is mostly supportive in mild croup. It's calming the child down, keeping them upright, and giving them some steroids. So steroids are very helpful because they reduce swelling. They reduce swelling by reducing inflammation. So something like, oral prednisolone is great, and it's easily given in the emergency room. If things are a bit worse, then you can consider nebulized adrenaline. The purpose of that is that the adrenaline will cause vasoconstriction of the blood flow into the inflamed area, and that will reduce swelling. So both treatments together will reduce the upper airway swelling. Bronchodilators have absolutely no role in croup, because croup has nothing to do with bronchoconstriction. It's an upper airway constriction secondary to edema from a viral infection. So make sure these are very different concepts in your mind, that asthma is the lower airway constriction, which may be triggered by a virus, but croup is an upper airway condition with an inspiratory stridor. There won't be wheeze because there's no constriction. Yes, the treatment involves steroids, which is common to asthma because they're both inflammatory processes, but the difference is the nebulized adrenaline, which has nothing to do with the beta-2 receptors in the lung. It's all about the alpha-1 constriction of blood flow into the mucosal tissue of that swollen upper airway. And this is just a slide summarizing that. So steroids, adrenaline.
Okay, so for the last drugs for the respiratory system, as we talked a little bit about lung cancer, I'm just going to give you a quick chemo summary here. Look, to be honest, this very rarely comes up on exams, but it is probably good to know a couple from this list. So just knowing sort of the classes and what they do is all you need to know. You don't really need to know the side effects at this point in your degree. You don't need to know that many names of stuff. You just need to know the classes and generally what they do. So I just have a little read of all of these. The ones that I like to remember, which just for some reason stick with to me, is your platinum analogs, because they cross-link DNA. I don't know why that sticks with me, but it does. And also your tumor blood vessel targeting agents. These reduce your blood vessel presence around the tumor. And these two I just find I remember easily, but whatever ones will help you remember. Just knowing 2 or 3 of these lists is probably the most important from that. And that's really all you need to know for chemo.
Let's quickly talk about some high-yield clinical aspects of the lungs. Pulmonary embolism. It's a blockage of the pulmonary artery or one of its deep branches, commonly by a venous thromboembolism, beginning as a deep vein thrombosis in the lower limb that has broken off and embolized to the lung. You should be aware that there are other forms of embolism, such as air embolism, fat embolism in orthopedics if you fracture a long bone and that fatty marrow gets leaked into the blood, or an amniotic fluid embolism in obstetrics and gynecology related to childbirth with a sudden onset of shortness of breath. Risk factors that you should be aware of are immobility, surgery, pregnancy, hypercoagulable states, and previous DVT or PE. So that's what you should ask on your history. And the things you should also consider that people might not think about is that you sit still on a plane, on a train, in a car, or at your computer. Surgery itself is a risk because you've had the body open, and that causes this massive inflammatory response that will predispose you to clotting months after surgery. Pregnancy because of venous stasis, but also the liver starts producing more clotting factors as your hormone levels change. And hypercoagulable states, so obviously cancer, but you should also be aware of genetic conditions like factor V Leiden, which we talked about in the ISM review lecture. But in case you've forgotten about it, factor V Leiden mutation is when your proteins CNS fail to adequately work. Now, some people have another condition, which is the protein CRS deficiency. That's where the problem's in the protein CNS itself. But in this case, factor V Leiden, the mutation is in the target of protein CNS, and it's also known as protein CNS resistance, factor V Leiden. The symptoms will be a pleuritic chest pain that's worse with deep breathing, shortness of breath, cough, and hemoptysis. But if you look at those percentages there, you could have someone who has none of those symptoms and all they have is a bit of tachycardia and a fever or something. This is just a slide again from the cardiovascular review lecture. I just wanted to remind you that in someone with what looks like a PE, you should also consider that, if they have chest pain and shortness of breath, it could be a heart attack. If they have, any of these other conditions should also be considered anytime anyone has pain in the chest because they can kill you. The scoring stuff. So there's an app called MD Calc, which is free. You don't even need an account. It's the perfect tool for going into your placements and into the future. So on there, you've got the Wells score and the Perk score. Both are good, but the Perk score, if you're over 50, you immediately get 1 point and can't rule out the PE, so you can't use it. And also your pre-test probability had to be lower than 15%. So it's really for the young, healthy person that has a bit of shortness of breath and maybe they went for a car ride and you want to know whether you can safely discharge them. That's when the Perk score will help. The basic parts are, does it look like a PE? Is PE your number one diagnosis? Are they tachy? Did they have risk factors like immobilization or surgery? Have they had one before? Are they coughing up blood, and do they have active cancer? You don't need to memorize that, but it'll stick with you eventually because those are the things that you'll ask again and again. If you have a low pretest probability, maybe D-dimer would be useful, but I actually haven't seen D-dimer used at all. And that's because if you have a high pretest probability and you really are worried, you should be doing some kind of imaging. If someone has good kidneys, the gold standard is a CTPA, but it requires contrast, so you can't do it if they have bad kidneys. So the alternative is a VQ radionuclide scan, which can miss PEs, but it can be done in someone with chronic kidney disease without issue. The treatment is our NOACs, apixaban or rivaroxaban, and The doses are a little bit different here compared to what they are in atrial fibrillation. And something you'll learn about in the future with these drugs is that there are 3 considerations to using NOACs: kidney function, weight, and age. If someone's kidney function is low, if someone's weight is low, and if someone is greater than, I think, 80 years old, you need to give a reduced dose of apixaban. Apixaban can be used with a worse renal function than rivaroxaban, and dabigatran is kind of just falling out of favor. So you only have 2 choices: apixaban, rivaroxaban. Apixaban can be used with worse kidney function, but it's 2 tablets a day, whereas rivaroxaban can be 1 tablet a day. If someone has cancer, though, because of the way the studies were done with DOACs, you still need to use therapeutic dose Clexane. So that's enoxaparin, but given at the higher dose, not the small dose that's given for VTE prophylaxis. How long do you need to take it for? Well, at least 3 months after your PE. And if the PE was unprovoked and you have no idea why it happened, but they do have some risk factors that kind of worry you, then you think, well, this person might just randomly have a PE again and die. They might need to be on anticoagulation forever. And that's a massive decision. If, say, you're in your 40s and you don't have AF and you've never had a stroke, and now someone's saying, oh, that little clot in your lung, I think we need to put you on rivaroxaban forever. That's massive. Whereas if it was provoked, so you recently had surgery or you broke a leg or something, and you've got no risk factors, you're otherwise young and healthy, then you could probably stop the anticoagulation at 3 months without being too worried. Percussion on the physical exam. Maybe you're good at it, maybe you're not. I imagine it gets better with practice, but there are some people that, I don't know, I guess it's just your anatomy, how hard you can hit your finger. Some people just suck at percussion, and if that's you, don't worry about it. Dullness to percussion suggests that there could be fluid or consolidation, such as an effusion or something like pneumonia or cancer. Hyperresonance to percussion suggests that there's a sort of very echoey chamber inside the chest if it's hyperinflated, or pneumothorax, it's just filled with air, you'll get a hyperresonant tympanic note on percussion. Auscultation, the things you should be aware of are reduced breath sounds in something like COPD or pneumothorax if it's unilaterally reduced breath sounds. That'll be coupled up with a hyperresonant note on percussion and possibly shortness of breath and maybe pleuritic chest pain. Bronchial breath sounds are normal over the trachea and sternum, but if they're heard in the lung fields, that suggests consolidation, which could be pneumonia, tumours, or even pleural effusion sometimes, because that will compress the lung from the outside, and then you'll have that bronchial breath sound conducted through the pleural effusion. It kind of depends a little bit on pleural effusion, whether it would muffle the sound or not. Wheeze, bronchoconstriction, the bronchial walls vibrating. Fine creps, coarse crackles. So fine creps are commonly pulmonary edema, heard best in the lung bases of someone with heart failure. Coarse crackles will typically be focal and suggest something like a lobar pneumonia, or if they're diffuse and they're on inspiration and expiration, it could be a condition like bronchiectasis. Friction rub and pleuritis. Stridor actually can be heard with your stethoscope by holding your stethoscope up to the child's mouth, and it will actually amplify a subtle stridor so that you can hear it on each breath in. Okay, let's finish off this lecture by talking about the highest of high yield stuff in the kidneys. So obviously renal is its own specialty with a massive amount of conditions, but for some reason in the Griffith curriculum, we kind of just do chronic kidney disease, AKI, nephrotic and nephritic syndrome, minimal change disease, and FSGS. There are many, many more conditions than that. And there are many other drugs that are used based on the kidney. But But given that we don't need to know that stuff, I'm going to leave it out. That can be your self-directed journey when you become very insecure in year 3 and realize that there's a lot of things to know that you've not even heard of before. So let's have fun with this section. So we're going to cover the physiology, basically, 2 points from pharmacology, some conditions that are high yield, and just finish off with some points based on kind of physiology and disease monitoring to do with GFR and the albumin creatinine ratio.
Alrighty team, so now we're onto the renal system, and I'm going to be taking you through what we kind of reckon is the most relevant for you guys to know in terms of renal physiology. Just a disclaimer, this is a more superficial look. It does get very deep very fast, so that's just a forewarning, but I think this is about the level that you guys probably need to know. So we're going to start with probably the most important thing for you guys to know is the GFR regulation and how this occurs and what does this essentially. So one of the major functions of the kidneys is to filter the blood, right? And it's to eliminate waste product and reabsorb all the stuff the body needs. And this is determined by GFR, your glomerular filtration rate. It's how much fluid is filtered by the kidneys essentially. And obviously if there's a reduction in GFR, this is going to cause a buildup of all the waste products within the body, and this is not good. So the body has lots of mechanisms that it uses to essentially regulate the GFR. So we'll start with internal mechanisms, things that are intrinsic to the kidney, before moving to the external controls. So in terms of internal mechanisms, the main one is the juxtaglomerular apparatus. And this is essentially a group of cells found around the PCT and afferent arteriole, which work to do the following. So the macular denser cells of the juxtaglomerular apparatus, these detect low sodium, right? So they're detecting a low amount of sodium passing through the filtrate. And because you can imagine, right, if the GFR is reduced, there's going to be a low sodium because not a lot of blood is being filtered through the kidney. So macular denser cells detect low sodium. These activate the granular cells, which then work to secrete renin and activate RAS. So as you might remember, so renin sort of activates angiotensinogen to angiotensin 1, then you've got ACE within the lungs and the liver, and that activates angiotensin 1 to angiotensin 2, and then angiotensin 2 works to do all various variety of things, all to increase GFR. So this includes stuff like inducing thirst, it's going to vasoconstrict your blood vessels, it's going to work to, and we'll learn a little about this, it actually will stabilize GFR, and it also works to activate aldosterone, which works to reabsorb sodium and water, and essentially works to try and increase your body's blood pressure to maintain GFR. You've then got your myogenic autoregulation. This is essentially the ability of the blood vessels within the kidney to resist stretching due to increased arterial pressure. So it's just a factor that is pretty much present in all major arterial blood vessels, where if there's an increased arterial pressure, they actually will constrict and to further increase the blood pressure to sort of prevent excessive stretch. Apologies, the slide was a bit messed up. So then moving on to the external mechanisms of GFR regulation, there's quite a few, but the most important ones I'll talk about. Probably the first most important one is the innervation of the kidneys. So this is done by the renal nerves, and which includes sympathetic fibers from the celiac plexus. It's good to note that there's actually no parasympathetic innervation of the kidney, so it's all sympathetic. So if you have an increased sympathetic drive, whether that's low blood pressure detected by the baroreceptors, it's a fight or flight response, anything like that, you're going to have an increase in sodium reabsorption, increase in renin secretion, and decrease in GFR, because you'll get vasoconstriction of afferent and efferent, which is just something interesting. So you're going to get increased RAS, but decreased GFR. You then have angiotensin II, which we just talked about. Now this causes constriction of the afferent and efferent arterioles. So it actually does decrease GFR, but it will maintain GFR usually because what it's going to do is it's going to increase the blood volume and therefore going to sort of maintain GFR where it's at. So it also, just to note, angiotensin II decreases renal blood flow as well, which is important for when we're using ACE inhibitors. You've then got prostaglandins. These affect GFR. They dilate the afferent and increase renal blood flow. It's mostly in response to hemorrhage or reduction in ECF. You've got nitric oxide, which dilates the afferent and efferent. So they're actually going to decrease. It's going to have not really a major effect on GFR. You've got your endothelin, which is going to decrease GFR. And you've got your natriuretic peptides, so this is ANP and BNP. So ANP is released in response to atrial stretch, and BNP is released by the ventricles. This is going to increase GFR by dilating the afferent and constricting the efferent. Just a fun fact, increased protein will actually increase renal blood flow and GFR. Just a little fun fact there. So now we've moved on from GFR and we're going to start talking about the actual functions of the nephron, right? Like what does the PCT do? What does the loop of Henle do? And I'm mostly going to start by talking about what it reabsorbs and what it secretes. So I actually really like this diagram. I can't actually quite remember where I got it from. Guyton Halls. That's where I got it from. And you can see here that essentially it gives you the ratio of each of these substances in the tubular fluid, so that's already been filtered, and the plasma. So you can see in the proximal tubule straight away, you can see that amino acids and glucose pretty much all reabsorbed at the PCT, the proximal tubule. Same with bicarb. Most of the bicarb is reabsorbed there. And then you can see that it's quite variable for all the other electrolytes and various substances. And we'll talk a little bit about that in the next couple of slides. So let's break it down a little bit more. So your proximal convoluted tubule, this here, as you might remember from ISM, this is all about passive reabsorption. It's all about following down electrochemical gradients. Some active reabsorption and active secretion does occur, but for most part I want you to think of passive reabsorption. And so it reabsorbs about 67% of the water, sodium, chloride, and potassium of the filtrate. It reabsorbs about 50% of the urea. So just a note of what urea actually does. So urea is a byproduct of a breakdown of essentially metabolism and everyday life. What it actually does in the kidney is it acts as like an osmolyte. So it's acting to either increase the water concentration inside the filtrate, or it's going to increase the water concentration in your blood. And it depends on where urea goes as to whether it's the first or the second. As I said, it reabsorbs virtually all glucose and amino acids in health in the PCT, and it reabsorbs most of the bicarb here as well. So this is the site of acid-base control. So then you've got your loop of Henle, so your Henle's loop. This generally absorbs about 25% of the sodium chloride and 50% of the water. It also reabsorbs some bicarb and other cations. The things to note here is that the descending limb is the only limb, the only part that is permeable to water because it has aquaporin channels. So it actually works to reabsorb the water and concentrate the sodium chloride in the tubular fluid. Whereas the ascending limb essentially works to reabsorb sodium chloride and bicarb. So essentially it's in the beginning part, it's just passively moving into the blood, but as you go up the ascending limb, it actually actively starts to secrete out the sodium chloride and potassium. And you might remember this horrible diagram as the countercurrent system. You don't really need to know anything more. That the whole function of this is essentially to try and concentrate the filtrate to enable it to be able to maximize the reabsorption and secretion of the things that the body needs into the blood. So it's trying to reabsorb all the things that we want and get rid of all the things we don't want. And it does this through this countercurrent countercurrent system. So now onto the DCT and collecting duct. Here is the site of active and controlled reabsorption. This is where most of the hormones work that we know about, so aldosterone, ADH. It is good to know that also working here is angiotensin II, adrenaline, and various other things, as well as these things do also work on the PCT as well. But DCT and collecting duct is where I want you to think about active and controlled reabsorption for the most part. So you reabsorb about 8% of the sodium chloride and secrete variable amounts of potassium, hydrogen, and urea, and the variable depending on the hormones that are at play and if you're in a metabolic acidosis, hyperkalemic state, something like that. It also reabsorbs variable amounts of water and urea, and this is all dependent, as I said, on aldosterone, ADH, angiotensin II, and other hormones. So now we're going to change tact again. And we're going to talk about blood pressure regulation and the role of the kidneys. We've done this to death, but we're going to do it to death. Hopefully for the last time for your systems, for the last time for year one, sorry. So, I'm going to run through this really quick. There's two main regulators for the blood pressure. It's your fast acting, your baroreceptor reflex, decreased stretch, decreased baroreceptor firing. The extra thing for you guys to know potentially is that they might want you to know actually the names of the brainstem areas that are controlling this autonomic response. So for the sympathetic system, this is controlled by the cardioacceleratory center, which kind of makes sense. Sympathetic is going to increase the heart rate. Cardioacceleratory center, name implies that it's going to increase the heart rate. So as I said, decreased stretch, reduced baroreceptor firing, uninhibition of cardioacceleratory center, activation sympathetic, you get sympathetic system activation. Then if you have increased stretch of your baroreceptors, you get increased baroreceptor firing, you're going to inhibit the cardioacceleratory center, and you're going to activate the cardioinhibitory center, which is going to do the opposite of what the cardioacceleratory center does. And I've got a little diagram on the right on what actually is happening here. Now that's the fast acting. Now the slow acting is RAS, and we've just talked about that in the previous slide, so I recommend you go back or rewind me talking and hear about the RAS and how it's detected and what it does. Great.
For this pharmacology section, I'm just going to copy in a section from my P4P lecture where I talk about the kidneys. Triple whammy is a related concept when you combine an NSAID, an ACE inhibitor, and a diuretic. As we said, GFR is best when the afferent arteriole is dilated, the efferent arteriole is constricted, and when there's enough blood volume around to give it to the kidney. If you give someone an NSAID, which inhibits the production of prostaglandins, you'll end up with a constricted afferent arteriole. If you give them an ACE inhibitor, you'll end up with a dilated efferent arteriole. And if they don't have enough blood volume to perfuse their kidney, then the whole thing falls apart. And that's what happens when you give them a diuretic as well. Now, given that you can buy ibuprofen in Woolworths, and that everyone's on an ACE inhibitor and that they might also be using a diuretic, this is a terrifying reality that it's very easy for people in the community to give themselves a kidney injury. The slide graphically showing that the ACE inhibitor inhibition of angiotensin II, it dilates the efferent arteriole, while NSAID's inhibition of prostaglandin production prevents the dilation, or in other words, causes the constriction of the afferent arteriole. And these things together will impair GFR, especially when combined with a diuretic. And here's one slide summarizing the stuff you need to know about diuretics. Now, I spent weeks learning how diuretics work on like a cellular level, and I memorized all the channels, and I was really happy that I knew which ones increased calcium and which ones decreased it and why, and magnesium, and I knew words like pendrin and NCEX. You don't need to know any of that. The stuff you need to know is that potassium-sparing diuretics act at the collecting duct. That's because the collecting duct is the place where potassium gets lost whenever sodium delivery is increased by other forms of diuretics. That's all you need to know about that. The drugs are spironolactone, which can cause gynecomastia because it's a steroid-based medication, amiloride and triamterene. Triamterene you won't see that much, but amiloride and spironolactone would be good names to know. Potassium-wasting diuretics are the ones that act anywhere before the collecting duct because they will prevent the reabsorption of sodium. Sodium will then float its way down to the collecting duct where it will get exchanged to promote the loss of potassium in the urine. So these diuretics are things like loop diuretics like furosemide or thiazide diuretics like hydrochlorothiazide. 3. Thiazide diuretics are used for hypertension. 4. Thiazide diuretics can make gout worse because they compete at the anion transporter for uric acid. 5. Loop diuretics can control fluid overload. So thiazides for blood pressure, loop diuretics for fluid overload. Loop diuretics don't actually fix you. They just make the symptoms go away. They don't help your heart at all. You still have heart failure, but the edema and pulmonary edema that's making you short of breath, that will resolve with furosemide. So it's symptomatic management of heart failure. Spironolactone, on the other hand, in point 7, is actually beneficial for mortality, and it's a part of heart failure therapy, along with a cardioprotective beta blocker like bisoprolol, carvedilol, and nebivolol, plus an ACE inhibitor or ARB, depending on if they can tolerate the ACE inhibitor. These drugs together have mortality benefit and will improve ejection fraction. And maybe in the future you'll have a fourth drug, the SGLT2 inhibitor empagliflozin, which was shown in the EMPA-REG outcome trial to be cardioprotective. But for now it's just the 3, spironolactone, beta blocker, and ACE or ARB. So when you think of diuretics and you want to know why one is used and not the other, thiazides are a part of blood pressure treatment, typically combined with another drug. They can make gout worse. They can also make diabetes a bit weird. That's not totally a proven issue, but the gout one definitely is. Loop diuretics for fluid overload, spironolactone for heart failure. Let's run through the renal conditions, and you don't need to know this stuff in an insane amount of detail, but it would be good to at least know nephritic syndrome versus nephrotic syndrome and diabetic nephropathy. Nephrotic syndrome is when you have a massive loss of protein in the urine due to some change in the glomerular filtration barrier, which should usually prevent protein loss. The most common cause in children is minimal change disease, and one of the most common causes in adults is focal segmental glomerulosclerosis. Those are 2 that you should know really well. And then there are other conditions that cause protein loss in the kidneys. But what you should know here is that nephrotic is the massive protein loss, and in children it can be minimal change, and in adults it can be focal segmental glomerulosclerosis. And the treatment of the 2 conditions varies, but I don't think you really need to know that at this level. If you understand what's happening here, it's very easy to predict what the clinical features will be. If you lose lots of protein at the kidney, you end up with low albumin in the blood. The liver will try to keep up, and it will go into synthetic overdrive and make lots and lots of new albumin, but you'll just keep peeing it out, and you'll end up with low albumin. Because you've got low albumin, you have a low colloid osmotic pressure within your vasculature, and you will begin to leak fluid everywhere. And one of the hallmarks of nephrotic syndrome is something called anascara, where you get swelling around the eyes and the face. And that just doesn't happen in many other things. You have to be so severely low in albumin to get anascara that it's almost a hallmark of nephrotic syndrome. Now, another thing that happens is that you lose other proteins, such as your antithrombin 3 and protein CNS. Now you might also say, well, why don't you lose all your other clotting factors? I don't know. But the simple way to look at this is that you lose your natural anticoagulants, and so you end up hypercoagulable. The risk here is that you are becoming hypercoagulable because of the protein loss, but you're also becoming severely dehydrated because of extravasation of fluid. And you can end up with blood clots everywhere, and you can especially get them around the kidney, which can make everything worse by changing blood flow dynamics in the kidney when they're already struggling. The things that go up are all of your plasma lipids, and you can get very, very high triglycerides, and this is basically because the liver is in synthetic overdrive. Now, if you look this up on UpToDate, what I just said is a myth, but they don't have a better explanation for it yet, so the way I remember it is that the liver just pumps everything out, protein and lipids. The other thing that gets low are your immunoglobulins. So you become immunocompromised, you lose your antibody, you lose your humoral defenses that come from the B cells. So things like pneumococcal and other conditions that you might have been vaccinated for, you suddenly lose that immunity because you're peeing out the actual mediator of your immunity. You can diagnose it by looking at how much protein is in the urine. You can do some blood tests. But basically it's a clinical diagnosis. The one thing that differentiates nephrotic syndrome from nephritic syndrome is that nephritic syndrome is a little bit more inflammatory, and so will have blood in the urine. The presence of blood in the urine strongly points you away from nephrotic and towards nephritic. Nephritic syndrome is an inflammatory process characterized by glomerular capillary damage, which leads to hematuria, pyuria, issues with water balance, and edema again. But the difference will be the blood. Nephrotic syndrome didn't have the blood. So it's the inflammation here that makes it different. That's the thing that makes you get hematuria and pyuria. There are loads and loads and loads of causes. One that you should know really well is post-streptococcal glomerulonephritis, and another one you should know well is IgA nephropathy. That's because IgA nephropathy is another name for a condition called Buerger's disease. But we won't go into that. But basically it is actually quite a common disease, so I think you should know it. The other one that you should know is Goodpasture's syndrome. Goodpasture's syndrome is an attack on the basement membrane proteins. It's autoimmune, and it can lead to hematuria and hemoptysis because it also attacks the alveolar basement membrane. Post-streptococcal glomerulonephritis is a unique kind of sort of hypersensitivity reaction when you get a strep infection. Those are the ones that I think you should know a little bit about. But if all you come out of this with is knowing that there's nephrotic and nephritic has blood and nephritic is inflammatory, I think that's enough. The general pathophys is that you have inflammation, you leak everything, protein and blood. You then also get a reduction in GFR secondary to this inflammation, which is a little bit complicated, but don't overthink it. Just think inflammation make kidney bad, done. So you can actually end up with volume retention because you're losing the ability to pump out urine. That's kind of different from nephrotic syndrome too, right? The diagnostic here will be looking at the urine, and what you're looking for especially will be red blood cell casts, which suggests that you have had bleeding into the filtrate and now it's in the urine. There'll be protein, and there might be white blood cell casts, suggesting that there's a white blood cell trans movement into the kidney. There are some antibodies that can tell you that there's inflammatory processes going on. ANA P answer and C answer. Anti-GBM. Antiphospholipid would be another one to look at with ANA, obviously for lupus. And cardiolipin, whatever. You don't need to really know all that, but basically there's nephrotic and nephritic. Nephritic has blood. Nephrotic is characterized by massive edema and a high propensity for clots, especially venous clots. So you have a high risk of pulmonary embolism during nephrotic syndrome and opportunistic infections secondary to the loss of your immunoglobulins. Diabetic nephropathy is one that you should know very well because diabetes, everything, it's very GPE because it's like primary prevention, secondary prevention kind of thing. We want to protect the kidneys of diabetics. In people with long-standing diabetes, they will eventually get chronic kidney disease. Okay? And something that you should know, and I think we talk about this more in the P4P lecture, is that if someone has inflammation of these little vessels secondary to diabetes in their kidney, you can guarantee that they've got issues with the little blood vessels in their retina. So their risk of blindness is very high. And vice versa, if you're examining someone's eye and it doesn't look right, you can be pretty sure that their kidney is looking pretty poor as well. In the same sense, coronary vessels of the heart are also likely to not be doing so well. But that's talked about more in a diabetes lecture elsewhere. You don't need to know the pathophys of this that well, but basically the two most common causes of chronic kidney disease are diabetes and hypertension, and it's worse if you have both of them at the same time. High blood sugar and your sort of inflammatory oxidative state in diabetes damage the kidney, okay? You get this thickening but scarring of the kidney called glomerulosclerosis, and you end up with a drop in GFR over time. The process, I guess the word that you should know is mesangial expansion, with thickening of the basement membrane, followed by glomerulosclerosis. The best thing to look at is the protein in the urine, which I'll talk about at the very end of this lecture. But essentially, there's a thing called albumin creatinine ratio, which tells you how much albumin is in the urine. And initially, there'll just be intermittent microalbuminuria. Every so often, they have a sample with a little bit of protein. Then, every sample will have a little bit of protein. And then every sample will have a lot of protein. And that sort of tells you how progressively dysfunctional their glomerulus is becoming, that it's leaking all this protein into the urine. How can you prevent it? Well, firstly, we want to control their blood sugar. But secondly, we want to put them on an ACE inhibitor because they're renoprotective. ACE inhibitors are probably a little bit better than ARBs at this for some reason, even though they basically do the same thing. ACE inhibitors are just shown in studies to be better. And certain ACE inhibitors have been shown to be better than others. You don't need to know that. Now, what you should take away from this as well is that if someone is young, has diabetes, but they're starting to get proteinuria, even if their blood pressure is like 130, you should put them on an ACE inhibitor if they tolerate it, because you'll protect the kidney. Even though their blood pressure is normal, you should put them on the ACE inhibitor because of the proteinuria. Kidney stones. So there's a bunch of different stones, and the things that you should remember are that calcium oxalate are the most common, that uric acid stones occur in gout, struvite stones occur in UTIs, and cysteine stones occur when people have genetic conditions that alter the reabsorption of cysteine, which is an amino acid. That's the main stuff that you should know. The struvite stones are also known to cause staghorn calculus in their morphology. And One thing to be aware of is that for the calcium-based stones, they can happen whenever there's hypercalcemia, for example, secondary to hyperparathyroidism. The features of any kidney stone will be a severe unilateral colicky flank pain, which I've spelt wrong in this slide. It radiates from the loin to the groin, and that'll change depending on where it is within the ureter because of the spinal innervation of the ureter. You'll get blood in the urine, nausea and vomiting, and unlike peritonitis, where the person wants to keep really still and not let their abdomen move, like in a late stage appendicitis or something, this person will be rolling around in bed in pain. They just can't keep still because they've just got this colicky pain going down their back. The investigations, the best one is an abdominal CT scan without any contrast. The reason being that when contrast fills the ureter as it's being excreted, that bright white fluid in the ureter might hide a stone. But also ultrasound can help because you'll detect hydronephrosis, and certain types of stones will be visible on ultrasound. The treatment is to provide hydration, analgesia, potentially antibiotics if it's associated with a UTI, and depending on the etiology, you can treat that. So hypercalcemia can be treated directly. Other things like, for example, the antibiotics for UTI causing stones. You can do all the different surgical things to break up big stones that won't be passed, but for the most part, most stones can be passed naturally with conservative measures. If someone has bad hydroureter and you're worried about them getting hydronephrosis and acute kidney injury, you can do percutaneous nephrostomy to drain the urethral pelvis and relieve that pressure on the kidney. Acute kidney injury. The best way to understand this is firstly the definition. The easiest definition is to say that there's been a 50% increase in creatinine within the past 2 days, or within the past 7 days above baseline, or an increase of 27 micromoles at any point. The kidney injury can be before the kidney, at the kidney, or after the kidney, pre, intra, and post-renal. Pre-renal, the things to think about is it's all to do with stuff that prevents blood from getting to the kidney. So things like hypovolemia, which can be from diuresis, diarrhea, dehydration, or bleeding, reduced cardiac output, loss of fluid, so like nephrotic syndrome, when you've got low albumin, the fluid is no longer inside the vessels. Cirrhosis, the same reason with low albumin. Or renovascular disease, if there's blockage of the renal arteries, you'll have less blood flow to the kidney. A renal cause could be in the glomerulus or in the interstitium and tubule. And there's quite a few different primary kidney conditions there, but be aware of glomerulonephritis, especially post-streptococcal glomerulonephritis, and be aware of acute tubular necrosis. Post-renal conditions are some of the things we talked about that could be the same things that cause vesicoureteric reflux, so posterior urethral valves, BPH, tumours, and stones. Kidney stones reduce GFR because they increase the hydrostatic pressure within Bowman's capsule, which decreases the gradient from the capillaries into the capsule to reduce filtration. With reduced net filtration, you end up with a reduced GFR. Kidney injury happens in phases, and this isn't really essential to know, but it's just good to have a general idea that, some event occurs, and it could just be severe dehydration. That's what it most commonly is in the hospital. And then within the next week after that event, the GFR drops, the creatinine rises, you begin to have electrolyte abnormalities and acidosis, and that's typically how you notice it. You'll see someone has a high potassium, then you'll see that their creatinine's high, and you put 2 and 2 together and you know that it's happening in the kidney. Then everything goes back to normal and they have an increased urine production, and then eventually it all gets better. chronic kidney disease. So this is different from an acute kidney injury. This is the long-term kidney failure that gets progressively worse. The most common causes are diabetes and high blood pressure, but it can also be after an inflammatory insult like glomerulonephritis, or PKD, or some kind of urological disease like the case with vesicoureteric reflux. Grading of chronic kidney disease is based on the albumin creatinine ratio in their urine, which basically just tells you how much protein is coming out in the urine. The more protein that goes out in the urine, the worse their kidneys are working in terms of filtration. And GFR. So as a GFR greater than 90 is normal, and as it gets down to less than 15, that's severe kidney failure, end-stage renal disease. When it comes to albumin in the urine, there's what you call intermittent albuminuria, which is every so often they will lose protein in the urine. That typically occurs in the early phase of disease, typically diabetes, and then it becomes a persistent microalbuminuria, where it's always there, and then it might become a macroalbuminuria, where it's detectable without having to use the highly sensitive measuring devices, and that would be the very final stages of kidney failure. You don't need to memorize all of this, but just be aware that with chronic kidney disease, you can have high blood pressure, or you can have issues to do with fluid balance in the body. And because of the retention of organic toxins, you get something called uremia, which is not due to urea. Urea is harmless, but it's called uremia because it's characterized by high urea, secondary to the kidney failure. You get tired, you have headaches, you have itching of the skin, anemia. Uremic pericarditis is good to know. So someone with kidney failure who presents with pericarditis, you should consider that it could be uremic pericarditis. Basically, every organ in the body gets unwell. And we know about chronic kidney disease mineral bone disorder. That's the secondary hyperparathyroidism from the urinary loss of calcium that results in continuous bone breakdown. Before I talk about hemodialysis, I just want to go back to acute kidney injury. Something that you don't need to know now, but I just wanted to mention is that if an acute kidney injury is pre-renal, it's typically because of dehydration. Now, there are two things that we talk about in the kidney and that are tested commonly on blood tests. It's urea and creatinine. Creatinine isn't freely reabsorbed in the kidney, so most creatinine that comes from muscle breakdown is filtered into the urine and then lost in the urine, whereas urea is freely lost in the urine but then also reabsorbed with water whenever you reabsorb water. So if you put that together, if someone's dehydrated, they will be constantly trying to reabsorb water because of antidiuretic hormone release, and within that water they'll be reabsorbing a lot of urea, so their urea goes up. But the creatinine doesn't get reabsorbed, so the creatinine in the blood doesn't go up. Putting that together, we can make something called a urea-creatinine ratio. When you put those together, if someone is dehydrated and it's a pre-renal kidney injury, the amount of urea relative to the amount of creatinine in the blood, the urea should go up because it's reabsorbed in the water, whereas creatinine is not reabsorbed. And in Australian units, which we use different units to America, the urea-creatinine ratio, if it's greater than 100, this suggests a pre-renal acute kidney injury because you're reabsorbing lots of urea when you're dehydrated. In other cases of kidney injury, there won't be that reabsorption of urea, and so the ratio won't be so high. And there's another ratio, but that's the main one to sort of have off the top of your head is Greater than 100, it's likely pre-renal dehydration. Talking about hemodialysis quickly, when someone has symptoms of uremia, that's an indication for hemodialysis. But the other basic ones, you can reason them out, and you can remember them with this AEIOU acronym. Acid-base, electrolytes, especially hyperkalemia that's become significantly high. Intoxication is when you're in the emergency room, that can be an acute hemodialysis indication if you've had some poison that can be hemodialyzed out of the blood, which not very many actually can. There's like a small handful. If you're fluid overloaded, so you've got pleural effusions, pulmonary edema, pericardial effusion, peripheral edema on the limbs, anascara of the face, or uremic symptoms. The other thing I put on this slide is a comparison of the composition of dialysate to plasma. Something to note is that the potassium is lower than the normal plasma level. That's to try and pull potassium out of the blood. All of this works by a diffusion gradient. So you can treat hyperkalemia by putting a low amount of potassium in the dialysate. People with chronic kidney disease, they get chronic loss of calcium. So you add calcium to the dialysate, but if you look at the number, 1.5 looks much lower than the normal plasma amount. But that plasma amount is it's actually including calcium that's bound to albumin, whereas the calcium in the dialysate is free calcium. So the 1.5 free calcium is actually higher than the body's normal free calcium. So that gradient will actually go from the dialysate into the blood. And then, of course, there are no toxins in the dialysate, and there are toxins in the plasma. So those uremic toxins will float from the plasma into the dialysate. And that's the principle of dialysis. It's just concentration gradients going both ways, depending on which one's got a higher concentration than the other. Just notes about dialysis. If someone's going to have dialysis long term, a vascular surgeon can create an arteriovenous fistula, which is used to make it easier to have dialysis. If someone has an AV fistula, you can't put a cannula in that arm because you risk blowing it up, and you can't take a blood pressure on that arm for the same reason. If you put your stethoscope over the AV fistula, it'll sound like a swarm of bees. Try remember this. Typically, patients will have a sign outside their door on the renal ward saying, "Do not cannulate the left arm. This patient has a AV fistula." Just something really good to know for next year that you might not always get told. And it's good for OSCE stations to mention it. You might get a point for that when you're consenting someone to have a cannula.
Renal artery stenosis is when the renal artery is blocked and so blood flow is reduced to the kidney. As we said at the start of this lecture, the kidney releases renin in response to what it thinks your blood pressure is, and the way that it can tell what your blood pressure is, in one way, is how much blood goes into the kidney. If less blood goes into the kidney, the RAS system will be more activated. So renal artery stenosis leads to RAS activation and hypertension. It's even worse if there's bilateral renal artery stenosis. Glomerular filtration is maintained by making sure that you've got a lot of blood going into the glomerulus and a high resistance of blood going out of it, so that, like squeezing the end of a tube of toothpaste, you can make sure that there's enough pressure inside that glomerulus to get the fluid out, to filter it, and I'll show you that on a diagram below. So blood goes into the glomerulus through the afferent arteriole, and that's dilated by prostaglandins. And then it exits through the efferent arteriole, which is constricted by angiotensin II. The best case for having a high glomerular filtration rate is if the afferent is really dilated so that blood can get in, and then the efferent is really constricted so that it's hard for blood to get out, which will increase the pressure inside the glomerulus, helping to push fluid across the glomerulus, increasing glomerular filtration rate. In renal artery stenosis, glomerular filtration is maintained because the efferent arteriole is kept in a constricted state by angiotensin II. If you give an ACE inhibitor, you remove the effects of angiotensin II and you will drop someone's glomerular filtration rate. That's okay if they've only got renal artery stenosis on one side, but if it's both kidneys, you'll drop the GFR in both kidneys and give someone a very serious case of acute kidney injury.
Conn syndrome is an eponym for primary hyperaldosteronism, which typically is caused, well, there are two forms. There's primary and secondary. In the primary form, at least, it's when you have a tumor of the adrenal cortex itself that is producing high levels of aldosterone independent of renin release. The high levels of aldosterone lead to everything that aldosterone does. It makes you pee out potassium, causing hypokalemia. It makes you pee out acid, making you metabolically alkalotic. It causes sodium and water reabsorption, making you have high blood pressure. And as a blood test result, you'll have low levels of renin, which is because that high blood pressure will inhibit the renin-angiotensin-aldosterone system. The CT scan shown on the right shows you a right adrenal tumor seen just underneath and posterior to the liver. The CT imaging of adrenal glands is basically you find the kidneys, and then on top of them, just medially and superiorly, there'll be two little flesh triangles, and those are your adrenal glands. DKA, type 1 diabetics who don't take insulin, or they don't know that they're a diabetic yet, and they're having their first DKA episode. They fail to uptake glucose into their cells, which results in polyuria and secondary polydipsia. And then their cells become starved, they break down fat, they release ketoacids in such a significant amount that you get ketoacidotic. You then get a high respiratory rate with deep Kussmaul's breathing because of your acidosis. The acidosis and ketosis makes you nauseous and want to vomit and cause severe abdominal pain due to irritation of the peritoneum. And all of that together means that the person will have ketones in the urine and blood, acidosis on VBG, deep breathing. They'll be fluid depleted from vomiting and urination that they need. They're basically in shock at that point if this is serious enough. But the point I want to mention in terms of the kidney is, what the hell does DKA do to potassium? It took me 3 years to decide what I think about this. So at first I thought of this thing where hydrogen gets swapped for potassium in the cells of your body. Potassium would then be high in metabolic acidosis. And then I did an exam question where it was like, explain why potassium is low in diabetic ketoacidosis. And that question broke me, because that was the end of first year and I thought I understood this. The way you need to look at this is someone with DKA, 5% of them will have hypokalemia. Okay, without any insulin treatment, they'll just be hypokalemic. 30% of them will have high potassium, and the remaining 65% will have normal potassium. So it is so painful to see that, you could pick anyone out and some of them would be high, some of them would be low, some of them would be normal. What you need to know is that in the absence of insulin, you are unable to pump potassium into your cells the way you normally do. So potassium will go high in the blood. But then, because of your high glucose and polyuria and vomiting, you will pee out lots and lots of potassium because of the flow of your urine. But at the same time, the osmolality of your blood and the lack of insulin, you'll keep drawing potassium out of your body cells. at a rate that's fast enough to maintain normal concentration of potassium in the blood, despite losing lots and lots of potassium in the urine. So what does this mean in simple terms? The concentration in the blood is normal, but the total grams of potassium in your body, if you weighed you, are less. That is a total body potassium deficit. You'll have a normal blood test, a normal concentration of potassium in the blood, but a low level of potassium within your whole body. Now, when you give that person just a taste of insulin, all their cells will start uptaking potassium, and they will go severely hypokalemic unless you supplement potassium, because their cells are starved for potassium. So it's kind of paradoxical, right? This person comes in really sick, but their potassium is 5.5, which is great. You give them just a drop of insulin and suddenly it's 3 and they're nearly dying. So that's my conclusion about DKA. The concentration in the blood is normal because of a combination of the high osmolality of the blood, which basically sucks potassium out of your cells, the insulin deficiency, which prevents it from going back into your cells, and the urination, leading to loss of lots and lots of potassium, which is then replenished by sucking it out of the cells. So the results will be low total body potassium, but a normal or even high concentration of plasma potassium, but 5% will be low. So there's my 3-year of thinking conclusion, which you might have known that. Maybe you got taught this, but I basically had to teach myself by doing exam questions, and the moment a question asked me why they were hypokalemic, my life was ruined. But I feel like now, given the explanation on AMBOSS and some other resources, I'm happy to say that DKA does not cause hypokalemia. It causes a low level, a low total amount of potassium within the cells, with a seemingly normal concentration outside of the cells in the blood.
Alright guys, we're nearly there. The last couple of things we're going to talk about is aging and GFR. So, aging leads to a reduction in the functional glomeruli and an increased prevalence of sclerotic changes. Essentially what this means is there is a normal decrease in GFR as age increases. You also get a decrease in to the blood flow to the kidney. And this is essentially just because you're losing functional nephrons. Now this is important because it complicates the diagnosis of chronic kidney disease in the elderly, as the line between the two is often blurred. So you need to check the kidney function over a relative time, right? So if they've, over 40 years, they've slowly declined in GFR, this is normal. If over a space of 2 years, they started to rapidly decline their GFR, this is when we start to think something abnormal is going on, right? And here's just a little number to put it in a number. After the 4th decade of life, so after you're 40, you have about an 8 mil per min loss per decade. So essentially, you know how GFR starts about 120 mils. This is going to go down by 8 per decade as you go age from 40.
Well done. This is the final slide I'm ever going to talk to you about, unless maybe I do 3rd year review lectures or something in the future. Or if you watch my 2nd year review lectures next year, hopefully they won't be too out of date by that point. Let's quickly talk about urinary proteins, the urinary albumin creatinine ratio. What is this? Why do we do it? Well, you're going to learn about it in 2nd year, but it belongs in the kidney topic, so I put it in the kidney topic. You want to detect protein in the urine because it tells you that the glomerulus is failing to prevent the filtration of protein, right? The glomerulus is a sieve and proteins shouldn't be able to get through, at least big proteins like albumin. So if you're peeing out albumin, that says that your kidneys are not doing so well. It has implications on mortality and when you're going to need dialysis. It's all about monitoring a diabetic to see if they are progressing into diabetic nephropathy and how severe it is. In the past, they would take a 24-hour sample of urine and test the albumin, but that means you have to pee for 24 hours, which people don't like. So what you can do instead, because creatinine is released at a pretty constant rate, unless you do something weird, the creatinine in a single urine sample can be multiplied up to tell you what 24 hours worth of that sample would have been. Because, you know what 24 hours of creatinine would be. You've got one lot of urine with some creatinine. You can multiply it up to make it equivalent to be 24 hours worth of whatever you're looking at. And the thing we happen to be looking at is albumin. So the single urine sample of albumin, if you know how much creatinine's in there, you could multiply it up to what 24 hours of creatinine would be, and that will predict what the 24-hour albumin would have been. Now, in reality, you don't have to do that, because now all the studies use the Albumin Creatinine Ratio, so you can just use that number itself as the prognostic factor. Albumin its release is changed based on what you're doing. So there are two main times to take this test to make it accurate. One is right after waking up. It's best done when you've been laying flat for a long time. So that's why doing it when you wake up is best. And there's one other time, but I can't remember it, and it doesn't matter for your exams. You can look it up. The importance is that initially in diabetic nephropathy, there'll be intermittent microalbuminuria. So the ACR ratio will be, not high enough to be called macroalbuminuria, but it's still elevated, but it's not in every single sample. Then, as the kidney gets more damaged, it'll be every single sample that has microalbuminuria. Then, as you get really sick, every single sample has a massive amount of albumin in it, macroalbuminuria. Why is this relevant? Well, let's say you've got a young guy, he's got diabetes, he's got a little trace of protein in his urine, he doesn't have high blood pressure. Well, ACE inhibitors, they are renoprotective by improving renal microcirculation, so as long as his blood pressure is high enough that the ACE inhibitor won't, drop it too much, he should be put on an ACE inhibitor to prevent the progression of diabetic nephropathy. That's an independent indication for ACE inhibitor use, separate from high blood pressure. So that's why we should test the protein in everyone's urine. Good luck, and thanks for a great year.